Hi guys, Dr. Gillard here. It is Tuesday. It is week 7. It's the spring of 2021. Here we go. Endocrinology day. So last time we just finished up at the end of last session, we were talking about the adrenal medulla and the fact that it has a different cell population. The main cell population are called chromophil cells. And they're very strange. They're almost, you can think of them as post-ganglionic sympathetic axons in a way, because they are stimulated by pre-ganglionic sympathetic axons, and they secrete sympathetic juice, kind of, the epinephrine, norepinephrine, a little bit of dopamine. Collectively, those are called the catecholamines. You should know that. So that's where we were. So then the next step is to talk about some pathology that has to do with these chromophil cells, these catecholamine secreting cells, and we can get a rare tumor that is made up of these chromophil cells, and the tumor is called the syndrome is called a Pheochromocytoma, and it is the most common tumor of the adrenal medulla. It's very rare. It says under 1% of people with hypertension actually have a pheochromocytoma, so it is a rare cause of hypertension. 33% of these are inherited. There is some gene mutations on many different chromosomes. You don't need to memorize those chromosomes, but you should know it's autosomal dominant, which means you just need one bad gene from mom or dad to get this thing. And the bad thing about this one is about 13% of them, if you do get this diagnosis, 13% of these are cancerous, especially the perigangliomas, which we'll talk about here next, or in a second. They typically don't strike both. Where do these tumors of chromophil cells grow? Because that's what they are. They're tumors of chromophil cells. They're not native, nicely placed chromophil cells. A chromophil cell becomes mutated and divides wildly, but it still keeps its function, and its function is to secrete epinephrine, or to secrete the catecholamines, but it doesn't need any input. It doesn't need any wires telling it it's time to secrete the catecholamines. It secretes it all the time, all by itself. So you get a tumor, and the most common place is in the adrenal medulla for this to occur. Right? It typically only the tumor affects, and the tumor, because it's made of hormone secreting cells, that's called the adenoma. We've talked about that. So this adenoma of chromophil cells usually affects only one kidney. It's pretty rare it's rare enough as it is, right? But super rare to get in the other kidney. So yeah, these tumors, again, they're mutated, made of mutated chromophil cells, so they have no control. You can't turn them on, can't turn them off. They just blast out the catecholamines. Norepinephrine, epinephrine are the main ones. A little dopamine as well. So a periganglioma is a different one. The AKA gives it away, so boards aren't going to tell you what a perigang, and they're not going to call it the AKA. The AKA is an extra adrenal pheochromocytoma. That tells you exactly what it is. They're going to say periganglioma. So about 10% of the cases, pheochromocytomas can occur outside of the adrenal gland. So 90% of the time, that mutated ball of these chromophil cells is in the adrenal medulla, but 10% of the time it's outside of the adrenal gland. You get a CT or an MRI and you look for it and you can't find it, and it ain't good. These perigangliomas, they're typically found in the chest, in the lungs, specifically the heart, the bladder, the neck, and the base of the skull. So they both of these, they oversecrete the epinephrine, norepinephrine, a little dopamine. So what effects does that have? Well, that's like giving you a shot of adrenaline. You're going to have hypertension, heart palpitations, hyperhidrosis, all sympathetic responses. Like if a tiger jumps out from behind the couch and scares you, that's the same type of response. You'll have hypertension palpitations, hyperhidrosis, you'll be sweating, headaches as well. The attacks of these symptoms don't have to be all the time. Sometimes they're paroxysmal, meaning they just come out of the blue. You don't have to be scared by a tiger. You could be sleeping, sound asleep at night, and wake up with a racing heart palpitations, and these symptoms, and high blood pressure, of course. I said that thing. Yep. And so, yeah, they can come on, or you can have it all the time. So that is the story with those. All right, that's all we'll say. It's such a rare tumor, and that's all I'll say about that one. You can obviously, to treat it, you have to cut out the adrenal gland. You can't just try to take out the tumor because it's usually too big. I guess you could try to do that, but they often end up taking out the entire adrenal gland. Remember, we saw the adrenal glands in anatomy. They're really squishy, soft, kind of like a degenerated sponge, or a sponge that's so but falling apart. It's so flimsy. I'm trying to think of a better example, but yeah, so you end up just taking out the adrenal glands. Then you have to go on tablets, of course. All right, so we were talking about Cushing syndrome. We need to finish up. We're switching gears back to Cushing syndrome now. Another common type of Cushing's cause is a unilateral adrenal adenoma. This time it's not in the medulla. It's not secreting catecholamines. This time it's in the cortex, the adrenal cortex, and it's usually unilateral, and it oversecretes cortisol. So this is a tumor made of what? This is a tumor made of what type of cells if it secretes cortisol? Fasciculata cells. Who secretes cortisol? Fasciculata cells of the zona fasciculata. So, so this adenoma is cranking out cortisol like crazy. It's considered, make sure, an easy question. Is it a ACTH independent or ACH dependent cause of Cushing's disease or Cushing syndrome? Well, yeah, it's cranking out cortisol. Cortisol is not being driven, so it has nothing to do with ACTH. So it's called the ACH independent cause of Cushing syndrome. So these unilateral, what's the treatment for the unilateral adenomas? Just the same as for the, just take out, you have to remove the kidney, or remove, not the whole kidney, you remove the adrenal gland. Just like if you had an adenoma in the medulla, you have to still take out the entire adrenal gland. That's called an adrenal adenectomy. Adrenal adenectomy. Will the patient, I put that as a surprise how many people missed this last quarter on the test. So a patient has a unilateral adrenal adenoma, which is secreting cortisol. So they have Cushing's disease. So the surgeon takes out the offending adrenal gland. Will they need replacement hormones, or do they just wake up and they're ready to go? Because there's two, right? You have two adrenal glands, and the other one's not affected. So you wake up and the other adrenal gland just takes off. No, the other adrenal gland will not just take off. It's damaged and it may never turn back on. So you will have to take replacement hormones. Why? Why would the good adrenal gland not wake up or not be working? That's right, the double negative feedback system. If you have tons of cortisol, your HPA axis is shut down. So your entire it's not just the other, the good adrenal gland won't work. All the machinery in the hypothalamus, CRH won't be produced. ACTH won't be produced. It takes a long time to get that machinery working again. Geez, I'm doing, I guess I don't know why I did this. So the good adrenal gland was shut off by the double negative feedback system. Yeah, you will need glucocorticoid replacements, at least for a few months, and you could try to wean off it and see if you can get your HPA axis to wake back up, but it may never come back on. So you might always have to take replacement hormones. What are the clinical findings in a unilateral adrenal adenoma? Well, how will ACTH and CRH be? If you have super high levels of cortisol, which is the first clinical finding, I should put that at the top, that'll shut off your HPA axis, so you won't make CRH and you won't make ACTH. So low levels of ACTH, low levels of CRH, high levels of cortisol. MRI or CT may show the adrenal gland very hypertrophic. Practice makes perfect. If the fascicular cells are constantly working, that tissue is going to expand, so you might see an adrenal gland that is big. What will the other adrenal gland look like? Well, that one's turned off, right? Because there's no ACTH to drive the fascicular cells, or the reticular cells for that matter. So it'll be normal, or it might even be atrophied a little bit from disuse. But remember, aldosterone, the glomerulosa cells still are working. So, all right, adrenal carcinoma is a really poor prognosis. Yes, adrenal. I actually have a patient right now who's got adrenal or he's got. We're not sure if it's a primary tumor or metastatic disease, trying to find out where it came from, but there is cancer in the adrenal gland, and it's not a good type of sign. Very poor prognosis. Usually, if it's primary, it's very, very aggressive cancer. Most patients are dead within 2 years. Adrenalectomy. So how do you treat this? You take out the adrenal gland again, right? You don't mess with this thing. You have to use hormone replacement therapies, the gold standard. You could try radiation therapy, but and remember, this type of cancer loves the spine. It can metastasize to the spine, and sure enough, it did metastasize to the spine in this case, the case I currently am working on. The treatment of ACTH-dependent Cushing syndrome. So that means it's dependent on ACTH. That means the tumor's in the pituitary, right? ACTH dependent means the release of cortisol, the Cushing syndrome, which is an oversecretion of cortisol, is dependent on ACTH. And remember, we talked about the most common cause is an adenoma of corticotroph cells in the anterior pituitary. And they're cranking out ACTH, and it can't be shut down by cortisol. The negative feedback system doesn't work there. The double negative feedback system doesn't work there. What's the treatment for that? Well, you take out the tumor. And that you can nowadays, transphenoidal endoscopic pituitary surgery can cut out the tumor. You can access it right through the nasal cavity and go into the sphenoid, through the sphenoid sinus, and the sella turcica sits right on top of the sphenoid sinus. The cure rates, or the success rates, are 80% for microadenomas, anything less than 10 millimeters in size. For the bigger tumors, it's hard to get all the tumor out, so it's about 50%. And then there's some problems with it as well. Here's that transphenoidal hypothesectomy going through the nasal cavity. You have to kind of break some bone there to get into the sphenoid sinus, break some more bone, and now we're at the pituitary gland. We're in the sella turcica. Specifically, the hypophyseal fossa is what we enter here. Alrighty. Now, what's the risks of this type of surgery? Well, the pituitary, we've talked extensively about its blood supply. So you're going to be cutting through that blood supply, and you may be a scar tissue type person, and you could scar up and damage that blood supply, and you could lose your whole anterior pituitary, could die off. Which is going to require the lifelong need for taking replacement hormones, which is not an easy thing to do. You could also get swelling inside the sella turcica, which creates a compartment syndrome. You can squish the pituitary, anterior and posterior, and that can kill tissue as well. So the entire pituitary may be taken out. If you lose your pituitary gland, you'll die, right? You have to have aldosterone to stay alive, or you have to have cortisol. You can't live without cortisol. That condition, by the way, if the entire pituitary dies, is called hypopituitarism. And if you do get a good result, trouble with these pesky tumors, they tend to grow back. So that's not good. What if the surgery fails? Well, if the surgery fails, then you're going to have to take both adrenal glands out. And this is for ACTH dependent, because the overproduction of ACTH is driving both adrenal glands. So you need to take both adrenal. Someone will say, well, why just take your pituitary out and you can save your adrenal glands? Well, the adrenal glands won't work without ACTH. They need and other hormones we haven't even talked about. So you can't just take out the pituitary. It's better to take out the adrenal glands. Then there's less replacement hormones that you'll need. It is a fairly dangerous operation, 4% mortality rate in good hospitals. But yeah, if you lose both your adrenal glands, you'll be on lifelong medications, hydrocortisone, and probably fludrocortisone as well. That replaces the the aldosterone. Even though hydrocortisone has some aldosterone activity, it's usually not enough, so you need to supplement it. Treatment for ectopic ACTH secretion. Well, that all depends where the tumor. We've talked about that. You can have a tumor of cells that secrete ACTH. It could be located anywhere, and so you got to find it. And unfortunately, a lot of times that tumor lives in the lungs and it's cancerous. So it all depends where it is on how you can treat it. If the tumor is in the tracheobronchial tree, which is bronchogenic carcinoma, or if it's in the thymus gland, which is called the thymoma, those are both the cancerous tumors, you can cut it out. You have a decent chance of excision of the tumor. It's a pretty good chance of cure, or at least helping the condition. If metastasis again has occurred from any of these situations we're talking about, very poor prognosis for metastasis. Small cell lung carcinoma is not operable. It's too diffuse, and you can't remove the lungs. So radiation chemotherapy is tried in these. Small cell carcinoma is not a great diagnosis. What's the medication treatment for Cushing syndrome? This is interesting. So this is met like egg, mater like pear, apone, meterapone. What does meterapone do? We have to go back to our little biochemistry days. It inhibits an enzyme called 11-beta hydroxylase. And if you block that enzyme, you can't make cortisol. Anybody see a problem? Anybody good in biochemistry and remembers that? What else does that enzyme do? It makes aldosterone. So now we have a problem. You're not making cortisol or aldosterone. But that's okay, because there's a solution. Easy peasy. No, there's not that easy, because you don't make aldosterone. But the aldosterone replacement is one of the precursor molecules for aldosterone, and that's called 11-deoxycorticosterone. And that is a super powerful mineralocorticoid. It's like aldosterone, but it's super powerful, and it's not normally around in great amounts. So let's go back to our biochemistry here. And you can see there's cortisol going to pregabalin. We're going over there to the for DHEA. And we're coming this way, progesterone, and progesterone is here's our enzyme. Progesterone is acted on by 11-deoxycorticosterone to ultimately create aldosterone. And by the way, it's down here. 11-beta hydroxylase is down here. So this meterapone blocks this enzyme, but it's in both pathways. So great, if we block 11-beta hydroxylase, you can't make cortisol. Yay, we've just achieved our goal. The problem is it's in this other pathway, so we don't make aldosterone. But what happens if you block 11-beta hydroxylase? Its substrate, 11-deoxycorticosterone, builds up, because normally this is siphoned off into aldosterone. And there's nothing wrong with 21-hydroxylase. So 21-hydroxylase keeps making 11-deoxycorticosterone, and it starts building up, and it's a super powerful mineralocorticoid. So the result is you're going to have hyperaldosterone symptoms if you're on this medication because of the buildup right here of 11-deoxycorticosterone. Everybody see how that works. So when these pathways get blocked somewhere, the backup products can be pesky sometimes. And plus, if there's a backup here, sometimes it drives more creation of adrenal steroids. So females could get a little more male characteristics, a little virilization going on as well with this condition. Okay, see how that works? But we'd rather deal with this problem than deal with Cushing syndrome, excess corticosterone or cortisol, because it's easier to deal with a buildup of this, and we'll show you how you deal with that right now. So yeah, so therefore Cushing's patients on meteropone will have mild symptoms of hyperaldosteronism, so they'll have hypertension, hypernatremia, and hypokalemia. And I'm not going to go through that because we've talked extensively about why that occurs. Go back and read the hyperaldosterone lecture or review the hyperaldosterone lecture. Yeah, and you can get some DHE overproduction as well. Right? Here's another, just to kind of throw in another disease. There is a rare condition called 11-beta hydroxylase deficiency, where this enzyme is not blocked by anything. It just is broken and doesn't work, and you're born with this enzyme that doesn't work. So therefore, you have low levels of cortisol, kind of an Addison's type presentation. But the weird thing is, you also have an excess of 11-deoxycorticosterone, and you can have hypertension from that, and hypernatremia and hypokalemia from this. Right? 11-beta hydroxylase deficiency. And the other thing is that it can drive. Remember we said if you block these, I guess I can draw, can't I? If you block the pathway here and here, it's going to drive it this way, and you're going to make the DHEA or the adrenal androgens, and that's in a female. It's going to lead to masculization or virilization. And here's a patient with a rare 11-beta hydroxylase deficiency who's got a little beard going on here because of all the extra androgens. All right, so that's a little rabbit hole. Back to the prognosis. What is the prognosis for Cushing syndrome? It's not good. If it's not treated, 50% of patients will be dead within 5 years. Usually hypertension related problems like stroke or heart attack. All right, so that is the end of Cushing's. I think we've talked enough about that. Let's look at these natriuretic peptides now and go down this little rabbit hole. So natriuretic peptides, aka natriuretic factor, it's natriuret, like Bedic, natriuretic. The major job is to combat hypertension and hypervolemia. They have the opposite effect of angiotensin II. They're the yang. If you do the yin and the yang thing, they're the yang to the yin of angiotensin II. There's 3 of them. There's 2 of them that are really clinically important. Atrionatriuretic peptide, sometimes called atrionatriuretic factor, or ANP or ANF. And then there's brain natriuretic peptide, which I don't think you know much about. It's really does the same thing. We're not even get into the differences. It's really the same thing as ANP. Then there's a relatively new type discovered, which is C-type natriuretic peptide, and we're not going to talk to. At the very end, I'll talk just a tiny bit about that because we don't know much about that. They're all made from the same gene, all 3 of these, but the proteins that cleave off the tails of the prohormones are a little different. And by cleaving off the tails in different places, it gives you our ANP, BNP, and CNP. All right, so let's look at ANP. So it's called atrionatriuretic factor, ANP, AMF, all those AKAs. It is a true circulating hormone. What is its job? There's the easy softball question. What's the job of atrionatriuretic peptide? It promotes or stimulates diuresis and natriuresis. What does that mean? diuresis and natriuresis? Well, if it's the yang of angiotensin 2, angiotensin 2 reabsorbs salt and water. This one kicks salt and water out. So it kicks water out into the filtrate, and it kicks salt out into the filtrate. And a better way to say that is diuresis is kicking water into the filtrate. Natriuresis is kicking sodium into the filtrate, or excreting sodium, excreting water. Okay? And if you do that, if you lose salt and water from the blood, your blood pressure will drop. Where is it released from? Is it the hypothalamus? Does it come from? Does it come from the anterior pituitary, the posterior pituitary? Where does it come from? Surprisingly, as the word kind of describes, atrial natriuretic peptide, atrial, it comes from the heart. So the heart is actually an endocrine organ. And specifically, it's secreted by atrial myocytes. So that's the first action, other than being able to conduct an impulse, a wave of depolarization. They do have some endocrine effect, and one important one is the secretion of ANP. And it's based on stretch. If you have higher blood pressure, it stretches the atria more, you'll release ANP. That's why they say exercise is good for hypertension, and it's because you're releasing ANP and BNP, and that's decreasing your blood pressure. Okay, so yeah, heart is an endocrine organ, and the ventricles secrete a little bit of ANP as well. The ventricles are where BNP is secreted mainly. About 95% of ANP is secreted from the atria. BNP, or brain natriuretic peptide, I always throw this on the test and people think brain, it must be secreted from the brain. I won't go into why they named it this. It was a mistake. They thought it came from the brain at first, but it doesn't. In animals, some animals it does, but the name stuck. It comes from the ventricles. Ventricle myocardial cells is where it comes from, and it's same thing. It's stimulated by hypertension, by stretching of the ventricles. And it mimics, for our purposes, its actions are exactly the same as ANP. So it causes diuresis and natriuresis as well. And it's a true circulating hormone. Okay, we should talk about the receptors just a tiny bit. So there's type A, B, and C receptors. Natriuretic peptide receptor A. That one is the main workhorse. It binds both ANP and BNP, and it's found in the same places that the receptors for angiotensin 2 are found. The kidneys, mainly the adrenal glands, smooth muscle cells, and the heart. It has the opposite action of angiotensin 2. So natriuretic peptide receptor B, that one is specific. That one doesn't bind. It doesn't bind ANP. This one's specific for CNP, which we haven't talked about yet. Right? So receptor A binds ANP and BNP. Receptor B binds CNP, which we're not 100% sure what it even does. This one is found in reproductive tissue and skeletal tissue. So it might have something to do with growth. As we'll see, I put those slides at the end. Confusingly now, receptor C, which you would think would bind CNP, it does not bind, well, it does bind CNP, but it binds all three of them. I think for C as clearance receptor, because that's exactly what it does. C means clearance. Clearance. And it binds all three of them, and that's how they're deactivated by this receptor. It binds them. We won't get into the mechanism. It binds them and shuts them off. All right. What are the physiological actions of ANP and BNP? Well, as we said, just the opposite of angiotensin 2. They kick out sodium, they kick out water, so that's going to decrease your blood pressure. That's the main role of these things. The lowering of pressure They lower pressure by affecting the systems, the place where they bind, by the kidneys, the adrenal glands, and the cardiovascular, mainly the arterioles and venules, by binding to the receptors there. Here's a great little chart of ANP and BNP. They just have A and F, but BNP does the same thing. So some specifics I want you to know. So there are receptors, type A receptors, in the magnocellular neurons. And so they can be shut off. They can shut off the production of ADH. Remember, ADH can also bind to angiotensin 2, which stimulates its release, and it causes a reabsorption of free water and increases your blood pressure. Decreased aldosterone, so they bind to glomerulosa cells as well in the adrenal cortex, and it causes the decrease of aldosterone. Causes decreased aldosterone release from adrenal cortex. Decreased renin, so they can bind to juxtaglomerular cells and decrease renin. They have just the opposite effects. These are exactly the opposite effects of angiotensin 2. What about cardiovascular actions, ANP and BNP? They do decrease sympathetic input from the heart as well, just the opposite from angiotensin 2. They're thought to interfere with the sympathetic ganglionic transmission that jumps from the pre-ganglionic fiber to the post-ganglionic fiber. They also stimulate parasympathetic input to the heart, which we won't get into the mechanism. That'll slow down the heart. They cause vasodilation of the ascending aorta, which also decreases pressure. Okay, so that means there's type A receptors, NPR, not National Public Radio, NPR A receptors on the tunica media of those vessels as well. And it causes general arterial and venular dilation throughout the body, just the opposite of angiotensin 2. What stimulates the release? This is going to lead to a little rabbit hole. Well, we know high blood pressure, hypervolemia, or hypertension. And then decreased cardiac output. How in the world can decreased cardiac output stimulate? Because I thought it had to be hypertension. If you decrease cardiac output, you're going to have hypovolemia, right? So how in the world can decreased cardiac output stimulate the release of ANP and BNP? So let's look at what happens. If you have decreased cardiac output from a failing heart, and it's got to be a failing heart, you'll have decreased pressure. So, I mean, when you first get a decrease, when your heart fails and you get a decrease of blood flow, you can compensate that by speeding up your heart. But that only lasts so long. Pretty soon, if your heart is so bad, you're going to start to have decreased blood pressure. The next thing that goes is the R2A system will turn on, right? It'll sense decreased blood pressure, and you'll get the release of angiotensin 2, which will boost the blood pressure back up. But the trouble is, when the pressure starts to get too high from angiotensin 2, you got a damaged heart, and the heart isn't good at releasing ANP and BNP. And this is controversial. This is not going to be on boards, I don't think. Because there's other factors and there's enzymes at play. We're not exactly sure how this works. This is one of the main theories here. But if the heart is damaged, you can't release ANP and BNP, so you can't correct the hypertension, which is driven by angiotensin 2. And we know how dangerous angiotensin 2 and aldosterone is, right? If you have too much angiotensin 2, you don't have a lot of angiotensin 1,7. Remember, that's the good guy. Too much angiotensin 2 will wreck the heart. Too much aldosterone will wreck the heart, which gets us in a vicious cycle, doesn't it? If you wreck the heart, it's going to decrease the pressure even further. With wrecking the heart, there'll be less ANP and BNP to offset angiotensin 2, and you develop hypertension. Everybody got that? What are things that can cause? Here's a rabbit hole slide, but a good one. What are things that can cause decreased cardiac output? Well, damage of the heart. Anything that wrecks the heart. So myocardial infarction wrecks a big chunk of the heart muscle, and you can't pump, and you have decreased hypertension, decreased blood pressure, and we just go through that same loop again. Valvular heart disease, aortic stenosis, aortic regurgitation. You're not getting enough blood out of the heart with those conditions, and the heart will get damaged from that. Ischemic coronary artery disease. That's the most common cause of cardiomyopathy, where the blood vessels in the heart get clogged up and your heart becomes ischemic and starts to die and loses its power to pump and causes decreased cardiac output, decreased stroke volume, and yep, same, back in that rabbit hole again. So any other causes of congestive heart failure. I mean, there's hereditary forms where you just don't, you're born with bad heart muscle. There's all kinds of things. We won't go any further down the rabbit hole than that. What are some other things that can stimulate ANP and BNP release? Chronic renal failure is an interesting one. With certain types of renal failure, the kidneys don't work, and you can't clear sodium out of the blood anymore. And if you can't clear sodium out of the blood, you can't clear water out of the blood, and therefore you'll have hypertension, and that'll stimulate the release of ANP and BNP. In fact, you can use ANP and BNP blood levels as a predictor of cardiac health, and a predictor. If those levels are high, that's usually kind of a bad sign that things aren't going well with the heart, and then the prognosis isn't going to be the greatest. The nephritic syndrome I haven't talked about yet. I had it in one time and I took it out because we just didn't have enough time. But remember, there's a nephrotic syndrome we talked about where the kidney is a leaky sieve. It leaks out too much sodium and water and protein. Can cause it can cause a general edema all over the body, even pulmonary edema. We talked about that one, but I didn't talk about the nephritic syndrome. Nephritic syndrome is basically an inflammation of the glomerulus and the glomerular capillaries. It could be autoimmune driven. There's several causes of it, but it's no good. The Bowman's capsule gets scarred up to the point where you can't get rid of the salt and water. You can't excrete salt and water, and therefore you have too much salt and water, and therefore you have hypertension. Right? Plus you have too much albumin, which creates too much of a sucking force and sucks the tissue dry, so it picks up too much interstitial fluid, which contributes to the hypertension as well. COPD, pulmonary hypertension. Yep, that can also stimulate the release of ANP and CNP. Chronic tachycardias can do the same thing. Pulmonary hypertension, how does that work? We should talk about that a little bit more versus the R2A system. What's the story here? Well, if you have increased pressure if you have pulmonary hypertension, you're going to have increased pressure, right? It's a beaver dam in the lungs, and it causes a backup of blood into the heart, which increases the pressure. Remember, we talked about how you could get a paradoxical embolism if you have a patent foraminal valley from this. But yeah, so if you have pulmonary hypertension, it's going to increase the pressure in the right side of the heart, and that side of the heart is going to start cranking out ANP and BNP. All right, let's see. And that will lower the blood pressure if you crank out ANP and BNP, because that's its job. The hypotension will have a problem. It'll cause renal hypoperfusion, which will turn on the R2A system. And so patients with pulmonary hypertension will have chronically high levels of angiotensin II because of this mechanism right here, as well as chronically high levels of natriuretic factors as well. Right, and that's kind of a bad sign if if your pulmonary hypertension is causing both ANP and BNP levels to be high. That's a really bad prognosis for the future. And yep, the failing heart indirectly stimulates the release of natriuretic factors, and we can use them. Although, see, that's where that theory of the failing heart, that one theory says that ANP and BNP decrease, where other theories say they increase. So they still don't understand how that works completely. Don't worry, I'm going to hit just the very easy stuff in this section because it's not well understood yet. I'll probably take these slides out. Alright, I said I'd talk a little bit about type C natriuretic peptide. And this is expressed by the central nervous system. Remember, brain natriuretic peptide, even though it says brain, is expressed by ventricles. It's not expressed in the CNS. People get that wrong, even though I'm telling you right now, probably half of you are really watching these or listening to these videos. You guys will get it right on the test. It's not, type CBNP is not expressed in the heart. The function still isn't well understood. Has something to do with growth, of skeletal growth, long bone growth. Might have something to do with vasodilation, so it could have a similar effect to ANP and BNP. It's not really a true hormone, though. It gets in the, it travels more by paracrine and autocrine function. And has a similar structure. We looked at the structure at the very beginning. Its half-life is really short, 3-minute half-life. And we don't know what regulates it. Does not seem to have a natriuretic effect on the kidneys either. So just kind of a FYI type thing. And we said the same gene makes all three of these. It's different proteases that create the molecule, which we're not going to get to. All right. See you guys later.